Good morning, everyone. Thank you to the one person in the front row who said good morning. Okay, we're going to try that one again. We got to get to talking this morning. Good morning, everyone. Thank you. And welcome to the 2016 CMS Medicare Advantage and Prescription Drug Plan Fall Conference and Webcast. My name is Stacy Pliska, and I will be moderating the conference today. This morning, we are gathered here in the CMS Central Office Auditorium, where the webcast is originating from. And we have a number of subject matter experts from CMS who are going to provide you with important new information on the Medicare Advantage and Prescription Drug Plan sponsoring organizations, the CMS staff, and other CMS partners. Throughout the day, we're going to learn about existing Medicare policies, new policies, policy updates, and technology updates. CMS experts will provide an understanding of enrollment and eligibility, as well as how to fight fraud and abuse within the Medicare program. Next slide, please. We would like to recognize all of our in-person and webcast guests who are joining us from all across the United States. Thank you to everyone for joining us this morning. Before we get started, I would like to just go through a few logistical items that will be helpful throughout the day. Next slide, please. And we have materials. The webcast materials are available on the CTEO website listed on the screen. So if you have not done so already, you can log on to the site to obtain the presentations to follow along with our speakers today. Next slide. If you are having technical difficulties, we do have staff members who are available to assist you. Please use the mailbox at CTEO tech support at cms.hhs.gov for your technical concerns or questions. Please also remember to use an Ethernet connection instead of Wi-Fi and Google Chrome versus Internet Explorer, and that may increase webcast streaming speed and prevent delays. The Medicare Advantage and Prescription Drug Plan Fall Conference and Webcast will feature interactive polling both during the presentations and at the end of the sessions for evaluations. There are a number of ways that you can participate. You can respond to the polling questions using any mobile phone and by sending a text message, or you can respond from a smartphone, computer, iPad, or tablet by visiting the Poll Everywhere web address. Next slide. If you would like to participate in the polling and session evaluations, to do so, you must first join my session. So please, let's do this together, our in-house and our virtual audience. If you would like to join via text messaging, go ahead and take out that cell phone. Select your text message screen, create a new message, and then type 22333 into the recipient or the to box. Next, you're going to type CMS 2016 Fall into the message box. This is not case sensitive, so it doesn't matter if it's upper or lowercase. And then go ahead and send your message. You will now be logged into the session, and that will remain open through the entire conference today. And you should receive a message saying that you are now connected. Okay, so then you would be good. To respond to evaluation questions, using your cell phone or smartphone to respond to a polling question, you will simply enter A, B, C, or D that corresponds with your answer and then hit send. To respond to the end of session evaluation questions, a question will come up that says, I would like to evaluate this session, or it's actually a statement, And if you go ahead and put A and then hit send, then you are going to receive a link back. And it's going to say, hello, please evaluate this session. There will be a link. You go ahead and you click on that link. And when you click on that link, next slide, please, you'll be taken to a Poll Everywhere site, just like the one that is here on the display. You will go ahead and choose Start, and then you are going to be presented with the evaluation questions one at a time. You answer the one question, you go ahead and you select Next, and then it will advance you throughout each question. And at the very end, you will hit Submit and then Finish, and your responses to that particular survey will be sent. If you would rather join Poll Everywhere via a computer, a tablet, your computer, you can go to the Poll Everywhere link, which is www.pollev.com/CMS 2016 Fall. Again, this is not case sensitive. And if you go ahead and put that in, it should take you to a slide that looks like the one that I have posted here that says the poll is not in session. Okay, as soon as we get to a polling question, that will change and you will be presented with the polling question. But this is the slide that you should see for now. Okay, responding to end of session evaluation questions and polling questions. The polling question will appear when the speaker prompts the question, or when they get to it on their slide. It'll automatically open, and you just enter your response by clicking on your answer. Next slide. Responding to end of session evaluation questions, again, is slightly different. When you are prompted by the moderator, you will go ahead and click on Yes in response to the question, I would like to evaluate this session. You will then, this is very important, be presented with a link that is in the green box. That arrow is pointing to it. You need to click on that quite quickly because it disappears. Okay, so you will go ahead and click on that link in the green box. Next slide. And it'll take you to a screen just like the one that I have up here. And you choose Start Survey, and you will be presented with the evaluation questions. You will go ahead and answer your question, and then you will click Next, and then at the very end, you will click Finish, and then your survey will be submitted. All right, so we're going to go ahead and we're going to give this a try with everybody, both in-house and virtual, whether you are connected via your cell phone or via your tablet or computer. And I don't even have to read the questions because you guys are pros already. Go ahead and let me know what song describes you today. Are you happy? Are you working really hard today? Are you just having one of those blah, creepy days, or is it raining where you are? Because we have a very beautiful, warm day here. Yes. All right. Oh, all right. Well, I'm going to hope we're going to stay with most people being shiny, happy people, and hope that we can keep you that way today. Next slide, please. All right. We look forward to everyone's participation, both our in-house guests and those that are virtual today. So our in-house guests will simply, when you have a question, come to the microphone that is in the center aisle. And for our virtual guests, if you have a presentation-related question during this conference, please go to the link that I have up on the screen, www.surveymonkey.com, and the rest of it, and you will be able to enter your question by session. We will then accumulate those questions, and we will be asking them of the speakers today. Next slide. Okay, if you have a technical question about polling at any point during this event, please send an email to tsanderson@providerresources.com, and she will be on standby to assist you. If you have a technical question regarding the conference or the webcast, please send your email to CTEO techsupport@cms.hhs.gov. And lastly, we are so glad to have all of you here with us today. Our agenda is packed with subject matter experts who are excited to share their knowledge and their expertise with all of us. So we're going to go ahead and we're going to get started. So kicking things off for us today, we have the Deputy Center Director of the Center for Medicare. Please help me welcome Cynthia Tudor.
Hello. Good morning to you. I'm sorry to say that Sean could not be here this morning, but I will try to fill his very big shoes. I'll keep this short so the speakers can spend more time with you discussing the current topics that are the subject of this conference. To digress a moment, for a very large number of years, this fall conference at CMS has focused on enrollment and improving plans' overall operations in that area. But now, while enrollment continues to be a problem for some plans, there's so many other areas where we want to assist you in improving operational readiness and overall compliance with Part C and D requirements. Today, you will have training on a broad number of topics. The first session that you have is a listening session on how audit findings might be reflected in star ratings. While you can certainly offer us your opinions on how to do this statistically, we are especially interested in learning what you think of the relationship between poor access to care, as demonstrated by audit findings that reflect plans' difficulties in the appeals, exceptions, and grievances processes for both medical and drug services, and the measurement of quality in MA and Part D. Improving access to care continues to be a topic of interest during the session on reducing the inappropriate billing of qualified Medicare beneficiaries, or QMBs. The session on MA operational changes offers help with the next application cycle to understand our requirements around network adequacy. While there's some pushback from plans on these requirements, we believe that a periodic review of an entire network helps to ensure appropriate access to care for Medicare beneficiaries. As stated in yesterday's news clips, access to insurance may not be the same as access to care. In a later session, we provide you with findings of our initial reviews of online provider directories. The session on improving operations through audits provides you with insights from an MA and Part D plan that gained additional understanding of CMS's expectations as a result of an audit. We're pleased to have Jenny O'Brien from United Healthcare and her team to talk about that experience. We also learned today about the early findings of a project that is attempting to develop care coordination measures. As you know, I've been pushing for this for probably 7 years. We still don't have many of them. After developing some proposed measures that look at areas that may show the lack of care coordination, the contractors will use MA encounter data to actually calculate rates. We also have an overview of one specific section of the Comprehensive Addiction and Recovery Act, known affectionately as CARA. That act allows the implementation of lock-in for at-risk individuals in 2019, subject to a number of statutory and upcoming regulatory definitions. Continuing with our concentration on improving plan readiness, you'll have a session on the different requirements of Section 504 and Section 1557, which respectively cover communications for people with disabilities and for people with limited English proficiency. Our staff have worked extremely hard on these presentations, as has our business operations staff. I want to thank them all for this work. I also want to thank each of you who are either present in Baltimore or on the line for your work for Medicare beneficiaries and for your participation in this conference. Have a great day and a great conference, and thank you for your time.
Thank you, Cynthia, for sharing with us this morning. Our first session today consists of a panel of speakers who will provide participants with policy goals and potential options that CMS is considering for star ratings and audit and enforcement actions, as well as the opportunity to provide CMS with early feedback into the process. So please note, we will be looking for your feedback during this session. From the Medicare Drug Benefit and C&D Data Group, please help me welcome Michelle Ketchum, Alice Lee Martin, and Sarah Galliot. I'm sure I messed that up.
Good morning, everyone. My name is Sarah Gallo, and I'll be starting off this discussion of options for adjusting Part C and D star ratings for audits and enforcement actions. Alice Lee Martin will then present on some updates to Medicare Plan Finder for sanctioned plans. The purpose of this session, as Cynthia said, is for CMS to listen to your thoughts on reevaluating the appropriate connection between sanctions, audits, and civil monetary penalties within the star ratings. We want to encourage comments and feedback on any adjustments to the 2018 star ratings early, in advance of our fall request for comments and draft call letter process. As I mentioned, another goal of today's listening session is for CMS to describe changes to the display of Medicare Plan Finder for plans under sanction. A little background. Previously, CMS's policy was to reduce the highest star rating for contracts under an enrollment sanction. CMS suspended this policy in March 2016 while we reevaluate the impact of sanctions, audits, and CMPs on the star ratings. Currently, we have one measure in the star ratings that includes sanctions, as well as civil monetary penalties and compliance activity module data. This measure is known as the BAP measure, or the Beneficiary Access and Performance Problems measure. Sorry about that. Skipping ahead to the next slide. Should be on slide 4. Oh, this one. Okay. One of CMS's most important strategic goals is to improve the quality of care and health status of Medicare beneficiaries. For the Star Ratings program, we aim to measure multiple aspects of quality. The methodology must be reliable in order to provide information on quality for consumers to make choices about their health and drug plans. Star ratings also must be valid because of the link with payment with the Quality Bonus Payment program. CMS aims to drive quality improvements of MA and Part D sponsors by publishing the star ratings each year. We continuously review the methodology for any enhancements that can be made with the goal of star ratings data accurately reflecting both sponsor performance and enrollee experience. CMS's policy goals for adjusting the star ratings for audits and enforcement actions are to reflect the magnitude of the issues in any adjustments. We also want to reflect the key audit findings, if there are any. We want to adjust appropriately, regardless of the source of the enforcement action. And finally, any adjustments must provide transparency to sponsors as well as to consumers. On this slide, we list some of the suggested options that we've received from industry for adjustments to the star ratings for audits and enforcement actions. The first option listed is to reinstate the reduction to sanctioned contracts' overall star rating. For example, we could deduct a value from the overall rating versus an automatic downgrade to 2.5 stars. Second option, CMS could also develop an audit measure to include in the star ratings. This measure could use audits conducted over the past several years. A third option is that CMS could revise the current Beneficiary Access and Performance Problems measure, the BAP measure, to reflect the varying sizes of the civil monetary penalties. This option would reflect the issues identified, as well as contract enrollment. As we said, the purpose of today's session is to encourage early feedback on any adjustments. We also encourage you to email us with any feedback on this topic at partcdqa@cms.hhs.gov. That email address is listed on this slide. We ask that you email us by September 23rd so that we can consider all comments before issuing our fall request for comments and the draft call letter in the spring. The 2018 call letter will include our revised policy for adjusting the star ratings for audits and enforcement actions. We'd now like to open the floor for your feedback on the options listed on the previous slide or any other options or thoughts that you have on this topic. We'll also have more time at the end of this session to continue the discussion.
Okay, so at this time, if you have some feedback, some comments, please go ahead and step up to the microphone in the center of the room. If you are part of our viewing audience, go ahead and you can send in via that SurveyMonkey link any comments that you have or any feedback that you have. Okay, well, if there is no comments or feedback at this time, okay, good. We do have someone who has a comment.
Sorry. Hi, so Michelle Johansson, Performer X. Hi, Michelle. Hi, Ann. Alice. So one comment is that while the BAP measure does currently include the audit, performance, and enforcement actions, there's still other measures that are also affected, so particularly in the Part D, like the coverage determinations and redeterminations, the timeliness. So one of the recommendations would be either find a way to consolidate everything into one measure because the plans are being disproportionately affected. So for example, if they had one late case and they, during the program audit, and they filled out that they had a case on the IRE universe, that's automatically being counted as a failure in the coverage determination and redetermination space. And we're seeing that plans are being rated as, CMS found problems. So it's counting in one measure and it's also counting in the BAP measure. And then otherwise, really just appreciate the opportunity to provide feedback, and we're looking forward to mulling over some of the options that you've given and responding by September 23rd.
Thank you. Thank you very much.
Okay, thank you for that comment. Do we have any additional comments or feedback? All right, there will be another opportunity at the end of this session to provide your feedback, so please mull over everything that you're hearing and take the opportunity to provide any comments that you have.
Stacy, I just wanted to also ask if people are watching through the webinar, should they use a SurveyMonkey to send in feedback?
Yes, they can send the feedback via the SurveyMonkey. The SurveyMonkey link that we had mentioned earlier, go ahead and in session number 1, provide your feedback instead of questions.
That's great. That way we can receive that feedback, and if you wouldn't be so kind to read, and then we can hear the whole discussion can be part of today's session as well.
Yes, absolutely. If we don't have an opportunity to do it during this session, we will absolutely do it at the end of the day during our open Q&A session.
Right.
Okay.
I also wanted to mention that Liz Goldstein is also part of the panel, so we're very happy that she's here. And please, we're going to take the next couple of slides to go over some Plan Finder changes. It's really information that we'd like to go through with you about the contracts under sanction, but it's also a chance for you to continue processing the information that Sarah mentioned. We will end again with another chance to come up to the microphone or email your feedback and make this really a listening session for us as well as for you. So the next slide. I wanted to show currently on the Plan Finder, if a contract is under sanction, we remove that contract from the display of Plan Finder completely unless you are currently enrolled in that contract. If you are an enrollee in that contract, you will still be able to see that information on your user view. However, the Plan Finder does not give much information about the sanction itself. We've received feedback from beneficiary advocacy groups that the Plan Finder should be promoting more transparency around CMS's actions, especially in something as serious as a sanction, and not just to beneficiaries that are enrolled in those contracts, but to all beneficiaries. We also were told that this is an opportunity to help communicate information to beneficiaries enrolled in those contracts because the information currently is only mailed to them, and we all know that something in the mail can be lost or not fully understood. So effective October 1st, we will be making changes to the Plan Finder tool so that all beneficiaries will be able to view information about a contract under sanction. So if you are not enrolled in that contract, you will still be able to see that on the Plan Finder. Also, we've created a new sanction plan button that will be displayed next to that plan. If you click on that button, you will be able to get more information about the sanction. And since a contract under sanction is not able to accept new enrollments, we will continue to suppress their data, such as cost information, premiums, deductibles, copays, and also their overall star rating. If you are enrolled in that contract, we will continue to display the cost information. We understand, of course, that is important if you are looking and comparing other plan options. One more time. So this is a screenshot that will show what it would look like if you go into the plan finder after October 1st. And again, you are in a contract that's not under sanction. You will still be able to see this plan, Test Plan 2, that is under sanction. It will be shown to you in your plan results page. You can see that there is no information shown in the various columns, such as costs, premiums, or coverage, and also no overall star rating will be listed. That new button, the sanction plan button, is to the far right in red, and if you hover over that, it states you can click it for more information. So when you click that button, a new pop-up window will open, and it will display text to the user. The text will explain the plan is under sanction for violating Medicare rules and cannot accept enrollments at this time. It also will provide a link to the CMS sanction notice that was sent to the sponsor. And here's a screenshot of what that will look like. And you see in the hyperlink, read this notice for more information. As I mentioned, we will suppress the overall star ratings information for a contract under sanction. We've also added that same sanction plan button to the far right of the star ratings tab. If you scroll down to lower on this same page, you will still be able to see the summary, domain, and measure level stars. This way, you can still see some performance indication of this contract. I think I need a new clicker. Okay. So in closing, and again, we'll go back to hopefully receiving some of your feedback and comments. In closing, we've listed a few important dates. We'd like to announce that the second plan preview for 2017 stars will be starting tomorrow, Friday, September 9th, and it will go through September 19th. This plan preview includes the measure level data as well as the star assignments. So please let us know of any questions or data issues that you identify by emailing us, and it's the Part C and D star ratings mailbox. And as Sarah mentioned, if you don't have the chance to give us the feedback or comments that you'd like to about how sanctions and enforcement actions should reflect in the stars, please feel free to send us an email after today. And we have a separate email address listed here, partcdqa@cms.hhs.gov. Again, we'd like the feedback to be sent in by September 23rd. That way we can incorporate any suggestions as we plan for the fall for the request for comments. The 2017 star ratings will go live on October 12th. And again, this fall we'll look forward to having the usual request for comments. So we're back to your piece of the session. Please think about and submit any comments that you have to us. We'd love to hear them. Also, ideas that we may not have considered.
Yeah. We'd also be curious to hear any initial reactions to the industry suggestions listed on slide 7.
Why don't I pull that up?
Okay, this is an opportunity if you have feedback, if you would like to come on up and step to the microphone. All right. Well, I do have one question that we have received for our panel, so I will go ahead and read that. And in the meantime, if you've thought of anything, please step up to the microphone in the center. And the question is, Has CMS reviewed the process for how retrospective compliance notifications impact current plan star ratings performance, regardless of the quality improvement that occurs after the compliance notification?
So I will take that question. So the star rating measures are calculated using retrospective data. So any performance improvement that would be shown or seen by CMS after that point would of course be incorporated into future stars.
Okay. Any additional questions at this time, comments, feedback? All right, then I would like to thank Liz, Michelle, Alice, and Sarah for providing the opportunity for all of us to provide feedback on the potential options that are being considered. Thank you so much. It is time now for our first session evaluation. So please take out your phones. If you will text your response or go to the Poll EV link if you are on your computer, smartphone, tablet. And remember, go ahead and enter A and send, and then you're going to get that link. And if you're online, click that link in the green box quickly. If you're on your cell phone, go ahead and click on that link, and then you will be presented with the survey. Go ahead and click Start and go through that survey. Our next panel will provide an overview of changes and information related to CMS's Medicare Advantage application review process. Here, to provide us with an understanding of the operational changes from the Division of Policy, Analysis, and Planning, I would like to introduce to you Stacy Davis, Teresa Wachter, and Marty Ablin.
Good morning, everyone. My name's Stacy Davis, and I work in the Division of Medicare Advantage Operations. I'm joined up here by my colleagues, Teresa Wachter and Marty Ablin, and they're from our policy area. And we are here to discuss with you some of the policy and application changes made for contract year 2017. Next slide. Once per year, CMS qualifies entities to operate as Medicare Advantage organizations. We're qualifying either new entities to provide new contracts as Medicare Advantage organizations, or we're qualifying existing Medicare Advantage organizations to expand their service area. Next slide. The Medicare Advantage application itself consists of three main components. We have attestations, which are typically just yes/no responses. We are reviewing to ensure that applicants meet our licensure and fiscal solvency requirements. And we're also reviewing applications to make sure that applicants are meeting network adequacy criteria. The application itself is automated in our Health Plan Management System, or HPMS. Next slide. Okay. So those three components are spanning across multiple sections of our application. We're going to talk about changes to three of those sections. That includes our administrative management section, our health service delivery section, and our service area section. We're going to describe the changes we made to these sections and also provide clarification based on various questions we received throughout the contract year 2017 application process. We also want to point out that we anticipate that these changes are going to continue for our contract year 2018 application, which is currently in the Paperwork Reduction Act or PRA process. So Marty, why don't you go ahead and begin talking about our administrative management changes?
Okay, next slide, please. So what we want you to take away from this slide is that, I think many of you know that there is a provision in the regulations that allows for CMS to deny, if you pull out, you withdraw a contract, you could be subject to a 2-year ban on reintroducing a new contract. This is the key question, or key element of this. This 2-year contracting ban is tied to the effective date of the contract, non-renewal termination, and the effective start date of the new contract. We're asking this because we want to make sure everybody's clear about how this works. And the other thing that's new here is this policy, or this 2-year ban, does allow for an exception under certain circumstances when we basically determine it's in the best interest of beneficiaries. And we have an upload mechanism where you could submit a request for, if you've had to pull out and you think there's a good reason, primarily in the interest of beneficiaries, that ban should not be upheld for 2 years, then you can make a special request to us. This is also an opportunity to play with our new technology where we can poll you. I have suggested that to kick it off, we ask you all.
Next slide.
Yes, thank you. Who your choice for president was, but I was overruled on that for some probably good reasons. So instead, we'll do something that's highly more relevant, a little drier perhaps, but highly more relevant. And here's the question, which I have to say, you have to read it a little closely. And I'll read the question, give you a chance to digest it. The 2-year ban applies when an organization non-renews an MA contract for an effective date of January 1st, 2016, and then applies for a contract with an effective start date of, and you have the 4 choices, January 1st, 2017, January 1st, 2018, and I see people already responding, but you're not all correct. So you have a chance to look again. But I'm going to give you a couple seconds. It was a tricky question. So it looks like we have a lot of Trump supporters here, which I'm surprised at. But I'm kidding. The actual answer, as you can see up there, is you chose correctly January 1st, 2017. And that is because this 2-year contract will run from, if you read the language, we're talking about when you're banned. And you're banned from offering a plan through 2016 and for contract year 2018. The question is asking when the ban applies for a contract, and it would apply through 2017. After 2017, then you would be eligible to re-enter the program, or if you felt you had a basis for asking for a waiver or an exception to this 2-year ban, something that you believe is in the interest of beneficiaries and whatever rationale you have, then you have the ability to submit that request, and CMS will take that into consideration. Okay, now I'm going to turn it over to Stacy for our next question. Oh, I guess I forgot that tricky part. The answer is A, January 1st, 2017.
So thank you, Marty. At this point, we would like to focus on the most significant areas of change for the application, which related to the network review portions of our application, or our health service delivery and service area changes in the application. So for the remainder of this presentation, we're going to be discussing what we changed and providing clarification around those changes. For that, I'm going to turn this over for Teresa so that she can give us a background on what drove us to changes for contract year 2017.
Next slide, please. Prior to 2015, CMS only reviewed MAO networks during the initial application and when there was a complaint. We have since moved on from this outdated method to a more comprehensive oversight of network adequacy. The GAO conducted a study on MAO networks, prompted by some MAOs' recent narrowing of their networks. In August 2015, the GAO released a report which recommended that CMS conduct more periodic reviews of MAO network information. As a result, we created a process that is in line with this recommendation. We responded by requiring full network reviews for the CY 2017 SAE applications. CMS continues to maintain network criteria that is fully transparent, objective, and establishes a level playing field for all network-based MA plans. But above all, this increased network oversight has promoted enrollee confidence in their access to robust, quality health care. So what is network adequacy criteria? First, as a reminder of our regulation, MAOs offering coordinated care plans must maintain and monitor a network of appropriate providers that is supported by written agreements and is sufficient to provide adequate access to covered services to meet the needs of the population served. CMS, with the support of our contractor, the Lewin Group, establishes quantitative standards each year to ensure that at least 90% of enrollees residing in a county have adequate access to a sufficient number of providers and facilities to provide healthcare services without undue burden. To define undue burden, CMS establishes quantitative time, distance, and number criteria each year based on the current market trends. These standards are published on the MA application website and also programmed into both the application module and the network management module in HPMS for the purposes of assessing the adequacy of an applicant's contracted network. These three elements of network adequacy criteria vary by both county and specialty type. Next, we will explain how we assess network adequacy.
I want to start off by talking about when we update our criteria. As you saw in the previous slide, CMS updates its criteria every year, and as a lot of you might be aware, this typically occurs in mid-January. The application is typically due in mid-February, so CMS likes to provide applicants with an opportunity to test their networks in the weeks leading up to the application. Prior to contract year 2017, applicants only had 4 opportunities to do this, and those opportunities occurred only prior to their submission of initial applications. With contract year 2017, we changed that. We wanted to provide you with the unlimited opportunity to review and test your networks, not just before you uploaded, but throughout the application process. And that's where this network management module comes in. For those of you out there who are existing Medicare Advantage organizations, we also want to let you know that this network management module is available to you 24 hours a day, 7 days a week. So operationally, you have a continual opportunity to test your networks against our current criteria.
Next slide.
So as Teresa pointed out, another big change with the contract year 2017 application was the requirement for service area expansion or SAE applicants to upload their full networks. Prior to contract year 2017, service area expansion applicants were only uploading their networks for their expansion counties. We announced this change through the Paperwork Reduction Act process, which was between June and October of 2015. So what did this full network review look like for service area expansion applicants with their HPMS or results? The applicants received their health service delivery or HSD county results based on labels showing whether the results related to an active county, which meant it was part of your existing network, or it related to a pending county, or it was part of your expansion counties. For contract year 2017, curative actions varied for applicants based on these labels, whether or not it was an active portion of your service area or a pending portion of your service area. So applicants who sought to remove an active county from their service area requested a service area reduction in HPMS, and that was through our service area reduction or SAR module. For applicants that wanted to remove a pending county from the application, this was done as it had been in previous years, where applicants submitted a request to our DMAO portal mailbox. I think this is a good point to move into a discussion regarding our exception process. So with that, I'm going to turn this back over to Teresa.
Thanks, Stacy. Next slide, please. So CMS acknowledges that continuously evolving patterns of care in certain service areas may necessitate exceptions to the network adequacy criteria. An MAO that does not pass the criteria for a particular specialty in a given service area may request an exception. However, exceptions should be rare and must be warranted. Justifications for an exception are based on other factors in accordance with the regulation that CMS determines are relevant in setting a standard for acceptable healthcare delivery network in a particular service area. Now on to exceptions policy. CMS recently clarified its exceptions policy in the January 15th HPMS memo. MAOs may request an exception if there is an insufficient number of providers available within time and distance criteria to meet the adequacy standards for a given county and specialty, as specified in the HSD reference file. However, the contracted provider network must be consistent with the current pattern of care and provide enrollee access to covered services that is equal to or better than the prevailing original Medicare pattern of care. Again, MAOs requesting an exception must provide conclusive evidence to CMS that the exception is warranted and these conditions are met.
So as an applicant, you have the opportunity to demonstrate that an exception is warranted by requesting one and submitting an exception request template. So let's talk a little bit about the format of this template. Prior to contract year 2017, applicants typically responded to a set of questions using a narrative format. Based on this, the types of information we received was inconsistent across our applicants. And because there was no page limit, we would sometimes have exceptions submitted that were 20 or more pages. As we move forward with contract year 2017, we looked to streamline and improve this template, which hopefully reduced burden on our applicants for contract year 2017. Specifically, we moved towards yes/no-based questions on the template and options to select specific data sources that might support the exception request. Another big change with contract year 2017 is because we were moving towards the review of full networks for service area expansion applicants. Any existing MAO that had a previously approved exception request was required to resubmit that exception request with their contract year 2017 SAE application. Another thing we changed is the timing of when exceptions came in. Prior to contract year 2017, applicants typically submitted exceptions in mid-March. We moved this up by approximately a week and a half, 2 weeks, and applicants submitted their exceptions on March 1st. And we announced this in an HPMS email at the end of February. As with prior years, our review of exception requests and our dispositions were communicated to applicants through the notice of intent to deny. So I think this is a good time to shift gears, and Marty's going to talk a little bit about our partial county policy.
Next slide.
Thank you. Our partial county policy has evolved in the last few years. And in the regulations, it's actually defined as the county integrity rule. And the reason for the county integrity rule, and what I mean by that is that except for extraordinary circumstances, We expect MA plans to serve entire counties as opposed to selecting zip codes of the county and excluding the remainder. And the reason for that, it's not an arbitrary decision on our part, is, as I'm sure many of you know, the way the Medicare payment rate is calculated for MA plans is based on counties and the cost of furnishing care for the range of beneficiaries that reside in a county. So we want to make sure that unless there's some compelling reason, and I'll talk a little bit more about that later, but unless there's a compelling reason why they can't serve the entire county, some parts of a county may be more expensive or difficult to serve, some may be easier, but the payment rate is based on the entire range of beneficiaries. So we would expect that unless there are some specific conditions that would cause us to allow a plan to serve a partial county, that entire counties are served and not partial counties. Next slide, please. And I'll say this, that our basic premise is, if we're looking at a county and we're cognizant, and there's a number of ways we look at this, but we're cognizant that there's a number of providers arrayed in the county that should make it feasible for an MAO to construct a network. By and large, we're going to require that, and if an MAO wants to serve that county, they're going to have to serve the entire county. In a little bit later slide, I'll talk about some of the circumstances when we would grant a partial county, because there are some of the counties have features or qualities that would cause us to be more flexible, particularly when we recognize it's in the interest of beneficiaries. But we'll get to that a little later, but I'm going to hand it back to Stacy right now.
Okay, so just like the exceptions process, you as an applicant have the opportunity to provide us with evidence that a partial county is warranted by submitting a partial county justification template. For contract year 2017, this template was modified to align with the policy clarification you saw on the previous slide, which is that the inability to establish economically viable contracts was not a valid rationale for a partial county. Also, just like the exception process, because we moved to full network reviews, any existing MAO that had submitted a service area expansion application was required to resubmit any previously approved partial county justification. In making this statement, I also want to point out that for both the exception request and partial counties, when that resubmission occurred, applicants were required to use the most current version of each of those templates that was published in January. So let's talk about how we reviewed the information that you provided to us, and this would be your exception request and your partial county justifications. Prior to contract year 2017, the exceptions in partial counties were primarily reviewed across 10 regional offices. For contract year 2017, we created a centralized team to review these requests and justifications. We created this team in order to leverage various skill sets that existed across our contractor staff, our central office staff, and our regional office staff. And we did this in order to build on our existing review processes and increase the consistency in the decisions we were making in the application as it related to network review.
Next slide.
So for exception requests, this team would verify the information that was being submitted by an applicant, which is basically we were verifying the request and whether or not an exception to our network adequacy criteria was warranted. We did this by reviewing what you were telling us on the exception request template and also reviewing public information that was available across various databases. We published an email in HPMS in April that identified these sources. We do want to point out, however, that in publishing these data sources in this email, this does not represent the sole list of potential providers and facilities that an entity can contract with to meet network adequacy criteria. We expect applicants to use any data sources out there, which would include commercial databases and private databases in order to meet network adequacy criteria. Okay, so it's time for a polling question. So think of this as kind of a pre-test into what we're going to move into. Think of yourself as you're part of this team reviewing an exception. Our question here is, which of these exception requests present a valid exception request rationale? Now, I'm not going to read all of these to you. So I see that people are still responding. We have some varied responses. So I'm going to go ahead and give you the correct answer. The correct answer is D, both B and C. Why are B and C valid? Well, both B and C are representing a rationale that is suggesting that there has been a change in the supply of providers within our network adequacy criteria that might suggest to CMS that the criteria can no longer be met. So let's talk a little bit about why A would not be a valid rationale. A is not a valid rationale because it says the exact opposite. What it's saying is there's a provider there within your criteria, we just haven't contracted with them yet. That rationale we would typically deny if that was received on an exception. We also find a lot of times that we're receiving exception requests when applicants might not have understood our HSD or health service delivery instructions. So over the next few slides, we present to you some examples of exception request rationales and how we would review them. We're going to skip through some of them. The first one we've already discussed here, which is the inability to contract. The next few go through the HSD examples I've just discussed, but Teresa is going to speak to one of those specifically.
Okay, let me find my place here. Next slide, please. Okay. So this example demonstrates that applicants should not submit exception requests as placeholders for incorrect HSD table submissions. The HSD instruction is that applicants may need to contract with providers outside of their planned service area, for example, in adjacent counties or even in neighboring states, in order to meet current CMS network adequacy criteria. We found that some applicants failed to do this when it appeared to be necessary. We have a written scenario here, but let's go to the next slide to see a visual of this. So here's a good graphic that depicts the idea of contracting outside of your service area. As you can see, the service area is Chester County, Pennsylvania, and the provider location is in Cecil County, Dr. Smith right here, the red star. And so Chester County and Cecil County border each other. They're in different states, but they're right next to each other. And you can see that the enrollees are located in southern Chester County, right next to the northeastern portion of Cecil County, which is where Dr. Smith is. So clearly, Dr. Smith is within CMS time and distance criteria for Chester County. The applicant should list Dr. Smith on their HSD table to provide access for enrollees in southern Chester County. So it doesn't matter that if the provider's office location is not within the service area, as long as the provider is within the appropriate time and distance of the enrollees in the service area.
So I'll reiterate a little bit what Teresa just illustrated. We, as was explained earlier, we review these networks that are submitted to us based on the best current data that CMS has about the location of practicing providers. You know, our data is never going to be 100% perfect. There's going to be circumstances where providers may have retired, moved, or they're just not available for other reasons. In those circumstances, what we expect you to do is we will make, you can request an exception, and if we concur that the data needs to be updated, then we will allow you to contract with an alternative provider. And it's important to notice that if you can't, within your service area or the general area, you're not finding a provider that you can contract with, that your information tells you there's not one available, then what you should do is contract with the next closest that you can locate. Because sometimes it's necessary to, for example, you may contract with a provider that's marginally outside of your service area, but accessible to your enrollees. But it's important that you identify the next closest. And, you know, and the reason is we're working with a database, but it's not a perfect database. We are constantly working to make our reflection of what's on the ground as accurate as possible, but it can never, ever be 100% accurate. And we also want to reduce the number of exceptions that have to be asked for by making our data good, but sometimes you're going to need to tell us that you have not been able to meet it, but you've contracted with this particular physician, which you believe is the next closest. So I'm going to turn it to Stacy next to follow on with this.
Next slide.
And before I jump into this one, just something I want to point out about the last slide is a lot of times when we see exception requests come in, we see exception to the criteria, but then no attempts being made to contract with another provider in order to provide access to beneficiaries. So what that last slide was trying to explain is we still expect applicants to meet network adequacy criteria in that 90% of beneficiaries are being covered through a contracted network. If because supply isn't there, you have to go outside the network criteria to do it, then that's what we expect you to do, and that's what you explain with your exception request. With that being said, we're going to shift gears again, go back to how this team reviewed partial counties. So CMS's review of partial counties is much like the exception process or review of exceptions, where we're looking to verify and validate an applicant's claim that a partial county is warranted. So part of this review does include comparing the service area to that of other Medicare Advantage organizations. If another MAO is operating in that area as a full county, our expectation, or what we believe, is that if another MAO is proposing to serve it as partial, then that may indicate that the partial county is discriminatory and thus non-warranted. Every time we look at a partial county justification, we're looking to make sure that all three requirements are being met or justified by the applicant, which is that the partial county is necessary, that it's non-discriminatory, and that it's in the best interest of beneficiaries. So at this point, we're going to test your knowledge again. Which of these partial county justifications present a valid rationale to demonstrate that a partial county is necessary? So again, you're the CMS review team. What do you think? Okay, so we have varied responses here again. The correct answer here is C. A section of the county has an insufficient number of providers to provide adequate access to care. So this is a huge area of the county. There's an abundance of providers that aren't available to provide access. So let's talk about why the others are incorrect. Providers, no one picked A, good. So I can skip that one. You all know that one. Or no, someone picked all of the above, never mind. So with A, if you go back to that policy, The inability to establish economically viable contracts is not a reason to request a partial county. And this is because CMS does not get in the business of contract negotiations between an entity and a provider. If a provider won't accept your rates, we're not going to grant you the partial county. Beneficiaries residing in zip codes that cross boundaries. Let's talk about this one. This is where you have zip code 51172, and it exists in both County A and County B. You're providing a full county. For County A, it's full, and you only want to offer services to the beneficiaries of County B that are in that zip code. We're not going to improve that. As Marty explained earlier, we set criteria at the county level, and we're looking at it at the county level. So trying to limit it to only a portion of beneficiaries in a county based on zip codes will likely be denied in terms of a partial county justification. So in the interest of time, we've got some examples on the next few slides. We're going to skip through a few. Teresa's going to start us off with the next example.
Okay, so this question, the question on the partial county justification, is it non-discriminatory? We're going to provide an example for this one related to this part of the partial county request. Applicants must provide conclusive evidence showing that their partial county request presents no discrimination. In this example, the applicant provides information to show the demographics for the entire county, but fails to offer any comparison based on the excluded parts of the county. We found that the applicant's claim that the partial county is non-discriminatory is not supported by any evidence showing that the healthcare costs and racial or economic composition of the population in the excluded portion of the county is comparable to the included portion of the county, or the proposed partial county. So for your reference, Chapter 4 of the Medicare Managed Care Manual, Section 140.3.2, provides a good example of rationale that would be acceptable to demonstrate non-discrimination. And we encourage you to use this as a resource when writing your partial county justifications.
I think with that, we're going to skip ahead to Marty to talk about another example.
So in this slide, the question is why we would grant, the circumstances where we might grant a partial county when we think it's in the best, and it's, in a way this is fairly straightforward. There are out west in particular, but other places where there's large geographic counties, and portions of them may include national parks, mountain ranges, areas that are basically very sparsely populated, few providers, and it may not be feasible to construct a network there to provide services. And so to the extent that we recognize that there are areas that are simply, maybe someplace in North Dakota or Wyoming or states like that, where it's just not feasible to build a reasonable network that's accessible to enrollees, then in those circumstances, we would grant a partial county. So I think to the extent that there's available providers, that's going to create a situation where there's going to be we would normally expect plans to be able to serve the county, and there would have to be some extraordinary circumstances where we would create a partial county in such a place. I'll turn this back to Stacy.
So let's just kind of recap what we discussed. We made several major network review changes to our contract year 2017 application. We required full network reviews for the service area expansion applications, which required resubmission of previously approved exception requests and partial county justifications. We also adjusted the exception request and partial county justification templates to align with our current policies and streamline the submission of information across applicants.
So the other thing we wanted to say is we recognize that this is big changes for all of you and maybe difficult and challenging, but we think ultimately this is going to be a win-win. win for beneficiaries and win for you, because the goal here is to create transparent, consistent standards that reflect what's facts on the ground and that are fair to everybody, and moreover, make sure that beneficiaries have robust networks. To the extent that it's difficult, we appreciate that. We're also going to be continuously working to improve this. We recognize, and your feedback is vital to us because we listen to it and we will make changes. It's going to be a moving target. The first year is the first year, but every year we do this, we feel like we're going to be doing a better job, and it's going to make life easier for you, and it'll make life better for beneficiaries. That's our goal.
And lastly, CMS expects that we'll carry the CY 2017 changes into the CY 18 application. Please note that the 60-day comment period recently ended for the CY 18 application, but organizations will have a second opportunity to comment. So keep an eye out for that, and we welcome your comments.
Okay, we are out of time, so if you do have questions for this session, please hang on to them, and you'll have an opportunity at the end of the day during the open Q&A session. And those of you in our viewing audience, please go ahead and send those in via the SurveyMonkey link, and we will get to those at the end of the day. And if you would like to evaluate this session, go ahead and enter A, and you can follow the prompts. And I would like to thank Stacy, Teresa, and Marty for the overview of changes in the application review process. Thank you. Our next session includes individuals from both CMS and United Healthcare, my goodness, who will share strategies to drive organizational change and move you to audit readiness status, as well as provide an overview of timeliness issues identified during audits. From CMS, we have Michael DeBella and Jennifer Smith. And from United Healthcare, we have Jennifer O'Brien, Kate Metzler, and Allison Green. Please help me to welcome them today.
Good morning, everyone. As many of you know, undergoing a CMS program audit can be a very stressful and time-consuming experience for an organization. It disrupts your day-to-day operations, places added stress on your staff, and requires time and attention of senior leadership. However, our hope is that these unwelcome short-term effects are offset by the long-term value an organization can garner by using audits to effectuate change within its operations. It's what an organization does with the information that it learns from an audit that can make the audit experience very worthwhile, and that is what this session is all about. Today we've invited compliance professionals from United Healthcare to discuss what it takes to improve operations through audits. CMS first conducted an audit of United Healthcare in 2011, and like most organizations undergoing an audit for the first time, the audit revealed operational deficiencies that required correction and a transformation in how they approach compliance. Here to speak to you about this transformation are Jenny O'Brien, Kate Metzler, and Allison Green.
Great. Well, thank you, Mike. We appreciate the opportunity to be part of this, but I want to start with a disclaimer similar to how CMS starts with a disclaimer. As we look at this and share some of our learnings and opportunities that we've discovered, just want to share, so we did receive an audit notice in 2016, and we're still part in that audit process. And during the audit, the CMS team asked if we'd be willing to come and share, as Mike said, about some of the transformation from the 2011 audit to 2016, and especially some of the success that we had embedding compliance within operations, as well as really gaining much more business accountability for the operations issues that existed within our organization. And so that's what we're here today to do, is share some of those. We believe they're applicable to whether you're a large plan or a small plan. And we really appreciate hearing from you all either during this or after of different things you've all done, because I think we all know we're on this journey together as we work to make sure that we can demonstrate effectiveness of our compliance programs. So if we go to, let me get this. There we go. I'm going to talk just a few minutes about our journey and our transformation. In 2011 to 2014, I would say our program was one of more reactive and responsiveness. And I think that as we look at it, we were all very committed. The organization was very committed, but I'm not quite sure we knew exactly what that meant. And if you want to call it the gift of going through the audit process, and it was late 2011 into 2012, and the validation really helped define for my compliance team and how we could better support the organization. And so we really sat back after that and thought, how can we be much more strategic and take what we learned? The door was open, so when you have these issues and you're meeting with CMS and you're going through the validation process, and it took us more than one time on different areas to get through some of the validation areas, and we continued to have conversation with Jerry and his team as we demonstrated what we were doing, but why we couldn't move some of these things a little bit faster. So the door was open, and so we really took that opportunity to stay in front of our business leaders and then look at to see what type of information, how could we be better in getting better information, better reports, more specific, more clear to our leaders who have a lot on their plate as well, of what they can do to help move to operational excellence and really improve operations and use those audits to do that. So that's what we're here today to talk about. In 2015 and 16, I would say with our program, we have really made a lot of progress to being proactive, strategic, and innovative. And for those of you who are all out there as compliance professionals, people are surprised when you say this is actually a job that you have to be very creative, strategic, and innovative. And I think that's why many of us keep doing that, is to figure out how do we best put in a program to fit our business model. And in the world of Part C and D, you go across operations, you go across pharmacy, marketing, sales. Each of those business models is a little bit different. Clinical claims now are added to the audit. So we really have an opportunity to think of how can we change our strategy so we can better serve our business owners and position ourselves to be more successful in the CMS audit. And we look at it not just the CMS audit, as CMS changes their strategy and methodology a little bit, it's happening in the ad hoc monitoring, so like the provider directory and network monitoring. So we're looking at it not just what do we do for this big audit that kind of brings organizations to its knees and halts it for a while, but how do we get sustainable so we can be handling the universe requests that come from all the different types of ad hoc monitoring auditing that CMS is moving towards. So with that, Kate, I'm going to hand it over to you to talk a little bit about what we did as we looked at the universe strategy.
So 2015 was really a turning point for our organization. As Jenny said, we began to look at things more proactively. And when we received the 2015 protocols, we worked with our business partners, to pull universes and populate the universe templates. And we failed at our attempt to create universes timely, according to what CMS would want us to do in order to get the universes submitted to them upon receipt of an audit notice. So we knew, as Jenny said, we needed to be strategic as a compliance program and to work with the business as our partners to figure out a way for us to accomplish that efficiently. So we reached out to our leaders, we explained the situation to them. We knew that put us at risk. If we couldn't get through the universe process, we weren't going to get to the walkthrough part. I mean, we weren't going to have a successful audit. So they understood that risk, and they committed to us resources so that we could engage IT, because we knew that our challenge was the fact that we had multiple data sources, and merging that information into complete universes timely, we were unable to do that with the basic tools we had. So I think that's one of the key things for people, is really to identify what is your challenge, and then engage the right people and seek out and push for the right resources in order to meet that challenge. So
Kate, I'm going to stop you for a minute. So when you talk about the IT challenge we had, can you share a little bit about how successful or not necessarily successful. Our first meeting was in bringing these groups together to try to ready our organization from an IT perspective, and why that was so important.
It was bumpy. It was bumpy at first, and people are very passionate about their operational areas. And the great thing is that there's a lot of respect. People know that we have the same goal. We're all headed in the same direction, but we all have different roles in achieving that goal. So it was important. We came together for this 2-day summit with IT and our business partners to really talk about that more, to say we have these resources committed to us now in order to make these improvements with IT. How can we use that? How do we need to decide together how we are going to use that? So we really wanted to simplify it. So for us to be able to come together in a room and talk about that really set us off in the right direction.
Yeah, and I'd say one of the things that we learned was we had to be very specific to our leadership about what we were asking about. So in the case that Kate was talking about, we went and set these meetings up and didn't ask anybody if they thought it was a good idea. We went and set it up, but realized if we didn't get some investment in the infrastructure of IT, we still would not be successful. So it was the reporting that we did, and then we came with a specific plan and an ask that our business owners that were in this meeting supported, IT supported. So it wasn't even necessarily us asking for that investment. It was our business partners and the IT partners saying to their leaders, to be successful, here's what our organization needs. So I think that was another change, is we had the ask as often as we could come from the business, not from our compliance team. Because as I say to our business, we don't have compliance issues. We have operational breakdowns that have now become compliance issues. So getting that operations ownership, even in asking for the funding, was, I think, a key to opening that conversation and being successful with the investment.
Mm-hmm. And it was important, to Jenny's point, that we were collaborative too, that we didn't just say to operations, here's the stuff, now fix it, that we were in it with them and we wanted to own that final outcome as well. So as much as we could collaborate and we could simplify, we built in a function. I don't want to say really a role, because it's not, we drew from existing resources and we identified, we referred to them as BPALs. So they were business partner audit leads, program area leads, who really, we asked each operational area to give us an individual who would be our point of contact so that we could manage all of this information and all of these efforts more efficiently. And that individual would be responsible for identifying risks, escalating issues, providing status updates. So we really had this core group of people who came together frequently to kind of set our path. So we streamlined that and made it more efficient. And it helped us manage more efficiently, it helped us message more efficiently, and it was crucial to how we proceeded.
Yeah, great.
Mm-hmm.
Do you want to talk a little bit more about how we managed, as we got closer to the audit and we got the audit notice, how did we manage CMS expectations? I joked with CMS at times of the audit lead, saying, did they wonder who got the short straw? I mean, who had got to come into United and try to figure out and manage our system. And so our goal really was to make it as easy as we could for the CMS team as well. And so when Kate talks about simplify, you want to talk about some of the things?
Sure.
And this was really an effort that Kate and her team led.
So we really knew it was important to be prepared, that what we wanted and what we talk about even before we had an audit notice is that we wanted to be calm when we received it. And we knew there would be some anxiety, but I think that that's one of the differences too, that we sought to be as prepared as possible. So if we had questions or the business had questions or we needed clarification, as you can see, there are a number of avenues. Today is a good example of places and people from whom you can receive information to help with that process. And the CMS mailbox was critical for us. Mm-hmm. We would submit questions to the CMS mailbox. They were very, very responsive. We could share that with our business partners so that in addition to measuring their performance with their own internal goals, they could also gauge performance and level of preparedness with what we expected CMS to be measuring and how they would be measuring it. So engaging in that way prior to receiving the audit notice it allowed for a more disciplined and even flexible approach when we did receive the notice. I mean, you can't predict everything, and I think it didn't make us more rigid. Like I said, it made us more disciplined and flexible. We had to do some changes with some of our speakers at the last minute due to unexpected surgeries and family things, and that allowed us to have other people step in and really pick up, and there wasn't hand wringing. People knew what their expectations were, they knew what their accountabilities were, and it helped us to move through it.
Yeah, I would say another change, because of all the tools that CMS gives us, and I'm not just saying this because I'm sitting in Baltimore right now, but the number of tools that are now available. I mean, the 2015 results just came out this week. We used every single thing that was given, and the responsiveness of the mailbox was fantastic, and I don't think we utilized that as well as we could have during our first audit process. But even in the industry, the way that industry colleagues are talking and sharing their experience of the audits and sharing with things that lessons learned or what they could have done better. So we really appreciate that, and that's one of the reasons we're here today, because of the people that we listened to in 2015 that had experienced things. And so I think that the tools and the transparency of the process that CMS has opened up for all of us is really helping us all become more accountable and become more prepared. As Kate said, our goal was, we were worried initially that we wouldn't get past the universe part. We could pull the universes initially, but it took us forever. So people were saying, okay, we're good, we can pull a universe, but when you add the time frames around and to get to timely and accurate, it was a whole new ball game. And so we were able to do many CMS mock audits and polls, and because the industry shared their experiences and CMS shared their expectations. Allison, do you want to, we'll go on to the next slide. Do you want to talk a little bit about the FDRs? That was another very challenging area for us.
Yeah, so when we went into the audit prep, obviously one of the things you have to look at is your FDRs and how you engage your delegates and how you get them to respond in a way that will meet CMS's expectations. So as Kate and Jenny have stated, when we first did universe polls, we included the delegates, and we wouldn't get them timely, and we definitely wouldn't get the universes back accurate. We needed time to work with them for them to understand what our expectations are based on our review of CMS. And we did identify significant gaps within our own compliance oversight as well as business oversight of their delegates to be able to pull together the information CMS is requesting, merge it with our internal data, and provide it to CMS within their time frames. One of the main areas that we had challenges with were our Part C claim delegates. This was not an area that was included in our 2011 audit, so this was brand new. Brand new for us, brand new for the delegates, and when we originally went and asked for universes, we got about a 20% response rate, and that didn't even include the accuracy part. So we then put several areas and resources and escalated to leadership to say, this is going to be a significant area of concern if CMS were to come in. At this point in time, we need to get an oversight structure in place, build up that business accountability so that they are taking ownership and understanding what the FDRs are to provide to us, and continue to test. So we did monthly tests, even ongoing for some other areas of pulling these universes. And once we would get down to being more timely with the polls and more accurate with the polls, then we'd be able to actually assess their performance. So we could get down to doing sample file reviews. But it took several months to get to the point where we were getting them accurate or getting them timely, and then additional time to get them accurate. So we had to constantly push, constantly bring it up to leadership and escalate where we weren't getting what we needed. But we finally got to building that sustainable and repeatable process that now we have the delegates engaged, we have everyone understanding what our expectations are so that we can provide the best response possible to CMS.
So Allison, can you give an example? When you talk about leadership, that's pretty broad. Can you give an example of how, and it did take a couple months, but how we were able to get pretty specific about who that leadership was?
Yeah, so we would take the time to really work through the business owners that we had through Kate and team with the BPALs on identifying just what people did, what was your role in operations, how did you identify what delegates were to be included, and would go up through the levels, up to the executives, to really get them to take the ownership that they need to oversee these delegates as if, you know, it's CMS overseeing us. It's the same role that we need to provide for them so that we can be sure they are performing their operations in a way that will make us succeed in an audit.
Yeah, I think one thing, you know, being part of the executive team at United Healthcare, is my team would be giving me really good information. And one example was, you know, we were struggling with one of our delegates and realized in a couple different places we didn't have real business owners over the delegate. And rather than compliance fill that gap, and I think in the last few years we would just step in until they could find someone, and then we ended up being that person. So we really stepped back and made sure we assigned a business delegate owner, and then compliance would support. We moved more into a supporting role. So we at times were enabling some of this behavior because we were stepping in and doing more than our role should have done, and as a result we weren't getting things fixed. And so that was on us. So when we went through this, many of it was what are we doing and what can we do better? By the end of this, we were able to go right to one example is our chief medical officer, where we were having issues with one system, and we stopped talking and let that person have a conversation with the head person of that area. And the conversation even got to the point of, you know, for the first time I've heard this is, are we going to de-delegate this because it's causing too much risk to our organization? Those are conversations that weren't happening in 2011 and 2012. And so we used this opportunity and all the information here to give our leaders the information they needed to be having some of these critical conversations. And it's amazing when you have those critical conversations, suddenly the information started coming in a way that was helpful. You know, the first time we did get we ran the real mock CMS with all the time frames, and we were kind of high-fiving because everything came in, and we gave it a little time and then said, okay, that was just timely. Now we need to get to accurate, right? And so it really was a journey, and we knew the CMS audit could be coming at any time. And you know, if we would have had this same audit in 2015, like some of the other organizations, I do think we would have pulled the universes. It would have been an amazing, you know, quite a process to get there. I think we, you know, would have had more of a challenge going through the universe testing that we did. We really got through that very smoothly, which was our goal. But if it would have been in 2015, I'll just be honest, you know, being able to have it in 2016 and learn from what was going on in the industry and that time helped us be even more prepared for 2016. So, Allison, do you want to talk a little bit about, as we go to our compliance program effectiveness? Oh, sorry, I'm hitting the clicker. Can you hit next slide for me? Thank you. So talk about our business accountability and some of the work that we did as we got past the universe type collection phase.
Yeah, so we conducted CMS-like audits. We incorporated this into our monthly monitoring plan. So we do have a monitoring team within the compliance team who would conduct monitoring on an ongoing basis on a variety of things. And when we realized we needed to have more of a focus on the specific audit protocols, since they were significantly revised in 2015, we decided to incorporate this into our monthly monitoring plan, where we would have the businesses run the universes. We'd have IT combine all the data so that we would get the universe like CMS would. We would review it for accuracy, pull sample files, and then do actual walkthroughs with the business teams. And we did this for, I'd say, about 8 or 9 months to truly get where we wanted to be. When we started out, it was red. We had several issues that would come up that would likely be considered ICARs or CARs, and we would just take the time to work through the corrective actions and then pull it again, see if we've made any progress, and if we have made progress, now have we opened up any new additional areas of risk? And all of this would be reported up to our senior leadership and CEO and the executives of UHC to show where we had our gaps and where we needed the business to really own the corrective actions and providing what the remediation will be to ensure that this risk is mitigated.
So Allison, could you talk a little bit about some of the concern we had that, we hadn't had an audit with some of these new protocols, and that how could we do a CMS-like audit without having gone through one, and the conversation we'd have about where some of the risk was and how we handled that? Yep, so we did our best to conduct a CMS-like audit, obviously not going through it with the new protocols. We didn't know what was going on. We didn't know exactly how CMS was going to come in and test us, but we used all of the information that Kate and Jenny went over previously, all the tools, enforcement actions, any of the reports on the website to really review and see, where would CMS rank this type of an issue and how severe is it? How many members are we impacting? What could that lead to when it comes to an enforcement action or sanction? And provided all of this information to leadership through monthly reports on this is exactly, if CMS were to come in at this point in time, this is where we think we would fall, to make them uncomfortable, to make them nervous that we wouldn't be where they likely think we should be. We wanted to incorporate it into our day-to-day lives, so it wasn't just a side project or an initiative we needed to do to get to and through an audit, but that we truly are working through each of the areas to make sure that we can do these processes on an ongoing basis. So once our 2016 audit is completed, to continue it for 2017, 2018, making it just a normal part of operations. Yeah, and as we looked at it, what made us feel better as we were going through it as well was we always did look at the member impact, and what it was, we realized it helped validate that we were moving toward a more proactive compliance program. We were finding issues sooner. The number of beneficiaries impacted quite often was small. And so this was great as we moved into our compliance oversight committees and our quarterly reporting and the reporting to the business. These became our key compliance indicators that just became really our business compliance oversight. And so our businesses then knew where some of the things, we had better conversations of where they were doing what they would call compliance monitoring. And we were able to show some of these results. We were able to change the type of the monitoring the business was doing as well, and make sure we were focused on the right things and being consistent of the areas that really did have the most impact to our beneficiaries. So it was a dual effort. We were getting ready for an audit, but it was also helping us make sure that we were looking at the right things and minimizing beneficiary impact, and also moving towards, how do we get to operational excellence, and making sure we were focused on the right things. So I would say one thing is the list of things we worked on used to be huge, and we were able to focus that list, narrow it down, fix those things that needed fixing, and then go on to the next things that came up. I think sometimes we just took too much on, and we're moving a lot of things a little ways, and this way we were able to move small things a lot farther to being fixed, and then take that next group of dig deeper into the issues. Do you want to talk a little bit about, we keep talking about reporting and escalating outcomes, of how we, maybe some specifics related to how we change that strategy? Mm-hmm. Yeah, so we met on a monthly basis with our CEO and executives of UHC to go over the results, go over how the universe polls were going and any of the sample file reviews that we conducted. It started out, it was a report template that was provided or built by us in compliance to really outline what we think, an audit report would look like, or how are we going to assess what we do. This is an example of that to show each of the different audit elements we have, how ready is the universe, if we feel we'd have any ICAR CARs or observations, and then making note of those risk areas. And at the top of each section, you can see there's an executive owner and a compliance officer listed.
It started off that we in compliance, since we built the report, we were using a lot of the data. We were the ones that were filling this out and speaking to it, to the CEO and other executives. And by, I'd say, midway through, it had gotten to transition to the business owners would come in, be prepared, the executives of operations of our clinical teams, pharmacy, would sit and speak to the CEO with us more or less in the background supporting them and having additional information to share, but they were truly the ones saying, you know, we weren't able to pull the universe timely, these are the 3 reasons why, and this is what we're doing about it. We identified these 2 issues, and here's the current remediation or corrective actions underway. And it was the business speaking to the CEO and executives on exactly what the status of their operations were and how it would be viewed from an audit perspective by CMS. And that really got everyone engaged and feeling completely accountable, because they were no longer looking at Jenny or us as the team saying, what are you guys doing? What is compliance doing? It was a direct conversation with the business leaders saying, how are we going to remedy these issues and get us to the best spot possible?
Yeah, so if anybody's interested, we'd be happy to share this. We thought we need to get a 1-page report that we can get in front of these executives, and to be honest, our whole goal was no surprises. And that was one thing I had committed as a compliance officer to our executives, was no surprises. So when we would look at this, we would think, if someone heard that, if our executive heard that, would they be surprised? And it went all the way to our CEOs, and using that as our mantra of no surprises, quite often was what we were able to figure out. Do we need to escalate this? And would they be surprised if they heard this? And so we even used the 2014 numbers on the first one and put industry-wide what the industry was. And in each of these areas, if we would have had an audit on that time and we pulled these claims and these different files, where we would be. And it was great to see the numbers, and it started with the universe. So you can see the universe are the big colors. I know it's hard to read there. But our first meetings were pretty much focused on the universe, but we were still working on all the other sample file issues, but kept the organization focused on the universe part, saying if we don't get these all the green, we're not even going to get to this part. And so people came to look for this every month. We had great attendance at every one of these meetings. I can't think of an executive who did not come to these meetings, and if someone was out of town, they called into that meeting. And so that's where we really looked at what is our role for the organization and how can we add value. And we recognized it was this type of reporting that would do so. And so we did restructuring on our team as well. Allison had been doing a lot of these reports off the side of her desk of her other work. And we realized one of the more critical roles was having someone that people could give information to, and Allison could help get it in a way that was effective, and we were able to influence decision-making in the organization by getting the right information. And it was simplified and specific and clear information. Allison, do you want to talk a little bit now as we go on to the compliance program effectiveness? I do have to tell you, we got a little nervous because we spent so much time focusing on the other protocols that we would meet as a team and say, is our own business in order? Because there were a lot of changes with the tracer methodology, and we had to do a lot of work to fit our issue track logging in a way that it was that CMS wanted it to be done. So one of the things I really was most nervous about was we were going to get the rest of the organization ready, and then this part would come in, and that's where we would be, you know, falling short of where we wanted to go. So I don't know if any of you have dealt with that as well. But there's some restructuring we did within our compliance team just to make sure we were going to be able to respond to a CMS-like CPE audit, because it was much different than the one we had gone through a couple years earlier.
Yeah, so when the 2015 protocols came out, looking at the compliance program portion, things were really completely revamped, and they introduced this tracer sample type of way, and we all kind of looked at each other like, what does this mean? I remember Jenny and I were at the HCCA Managed Care Conference when it came out, and we were like, we need to dig into this. We need to get the team together. We need to understand, how is this changing? It went from, in 2011, really document-based, where we'd provide all this information up front, and then they'd do interviews, to us needing to show them how we work through issues and how we do our risk assessments, do our monitoring, make sure that we are effective in our corrections. So we restructured the compliance team into a prevention, detection, and correction model, which really helped us ensure that there is role clarity. A lot of what we were doing before is we'd have compliance people supporting certain operational areas, and it would be more or less all hands on deck for a certain area. So operations, you'd have a few people that could work any of the monitoring, policies, procedures, all of our corrections issues. And what we did was kind of take a step back and say, how is this new tracer sample going to show to CMS how our program works? And what does prevention mean? What does detection mean? And what does correction mean? What does, where do those different things, the 7 elements, fall into that? And how would they expect to see that we're interacting with the business areas through that? So we built the team and used the tracer PowerPoint and the template to really outline what we'd want to do. The thing that we learned and that we were happy with is we used CMS's template as an example only. As we were filling it out, it didn't necessarily make sense to walk through our issues the way that CMS had outlined it, and we were able to have conversations with them to say, can we revamp this a little bit? Can we do it in a way that we can help you guys understand how we are processing issues, how we are working through our elements of a compliance program, and really built out the team in a way that could respond to it more easily and not have it be so burdensome to obtain all this information and documentation on every single issue, but make it more of a streamlined approach. And what resulted from that was also building in what CMS expect into our issue tracking database. So any information that we would need to obtain on an individual issue would also be automatically entered into the database so we could report on it to CMS. One of the other things that we did that we discussed with our auditors when they first came on and gave us the engagement letter was, could we do an overview in the beginning? Could we provide an overview of our compliance program end to end, and then focus each of the tracers on an individual issue that they selected from our universes? And that gave them a more robust view of our end-to-end program, so that then when we got into those tracer interviews, we could really focus on, what part of our process did this come in, how did we work it, and what was the end result?
Mm-hmm. Yeah, I think the prevention, detection, correction structure has also enhanced how we talk to the business about what we do. And now I think it's helped for role clarity about how we can support them and how the business monitoring it needs to happen in the business, and they need to do their own business monitoring, and what is our compliance oversight over that, and how can we help prevent issues from happening, how can we still be there to detect and find them, and then a real formal correction process. And so I think, as I look at the tracer methodology, that was a great exercise, and I think it enhanced our program, and it's something we're going to keep doing. To say when we tell our story, we document things better than we had in the past as well. We were having many of the right conversations, and we have a very strong process to escalate issues and a very robust compliance oversight committee, but we couldn't always demonstrate it in a way that we needed to. And so I think this, the tracer methodology probably has been one of the our team actually had fun with it, learning what it did and putting it together, and now enhancing how we actually do our tracking and reporting out as well.
Yeah, and the last thing noted on this slide is follow the process. I'd say that was another mantra of ours, in addition to the no surprises. We, my team with Kate's team, had really built up the processes for responding to the audit overall, for performing in the audit, and unlike 2011, where we more or less were just reacting to anything that came in, we had built the different ways we wanted to approach certain things. And when things would come up that maybe we weren't expecting, or people always want to know information right the minute something happens, we would repeat over and over, follow the process. And I did it several times on Jenny when CMS would be coming on site. I would, there'd be something that comes up, and All I would have to say to her is follow the process, and she would back away, and then we'd provide the information when it was there. So it's really allowing the compliance team, the business teams that are working the day-to-day to have control over what is happening and ensure that, you know, we will include leadership, we will include executives as we need to make sure everyone is included and involved, but also allow us to do the work that we've built up for such a long time.
Yeah, I think the follow the process also worked with the business is we have so many well-intended business partners, right? And they want to come in and help. And what we learned to do is, and sometimes we want to go in and help them. And so what we learned through this is if we stay within our roles and let each of us do our jobs, and if we define those a little more clearly, there is enough work for all of us, but we have just become more cleaner in the work we have done. And as a result, I think we're getting better results and outcomes in the operational issues that we're looking at faster, and not duplicating effort and duplicating work, and making sure we're aligned on what's the outcome we're looking for, what are the measurements, and so forth. So I think we've become a more disciplined program, and it's easier for people to understand what our role is, and us to also help the business understand what our role is and their role is, and has really moved both the business and compliance much farther ahead, and is impacting operations as well. I know another thing that the journey has helped is, we used to talk about, look at the 98% of here's where we're at 99, and so the other thing that the CMS audits have helped focus on is the message we had been saying. They don't care about that percent. They're going to look at this percent, and these audits have shown that. And I think that's really changed the mindset in our organization, as we don't spend time talking about the 98 or 99% anymore. We now talk about the 1% or the 1 member or the 10 members instead of the other ones that did receive their access to care, access to services. And so our conversations have shifted of where our energy is spent. Instead of the 98, we're now spending the energy on the 1 and 2%. And I think that is also just a great advantage to the beneficiaries that we're serving. Just to bring this home a little bit, oops, can you go? Oh, lunch, there we go. You guys are like, awesome. If you can go back. So just the last slide, yeah, I just wanted to share it. So there is still more to learn. I was telling some of my industry colleagues here, this is not a comfortable place to be sitting up here talking about this, because we still see all the things where we aren't yet. From the audit, we haven't received our report yet, but we know where the findings are, and we're working on things, and there's just so many opportunities to continue to improve. But what we feel good about is our hard work is paying off, and I think we're much more focused and able to affect change much more quickly. But just want everyone to know we have not figured this out. It is a journey. We continue on it. That's why I would love to learn from folks. We wanted to share that tool we did. If that's helpful to anybody that can use that was something that worked for us, may not work for you. But it was an effective reporting tool that our executives did respond to, and we got the responses we needed. We are moving, as I said earlier, to an audit readiness that is beyond the 3-year audits. We continue to get universe requests in 2015 of some of these ad hoc audits that we would have to ask. They wanted it in 5 days or 8 days, and we'd have to say we need 10 or 12. We need more time. And so it's our goal that we can be more sustainable, and when those requests come in, that everybody doesn't have to be pulled off a job and to be able to deliver what CMS is asking for us, but that we've embedded that into the daily operations work, and those are the expectations. So that journey does continue, but that's what we're focused on. And then just the best practices. We just appreciate, at the last Managed Care Conference, there was a panel of 3 of our colleagues that really shared the good, the bad, and the ugly of what happened in the audit and what they could have done better, and we sat and scribbled notes. And so the more we as an industry share some of these things, then I think the more we can continue to all get to that effective part of our program. And with that, Jen, I'll turn it over to you.
Okay, thank you. So I did have a few questions for you guys. You talked a little bit about some of the struggles you had with your FDRs, mainly around getting proper universes, but can you talk a little bit more about what was your rollout or communication strategy, making sure that everybody, all the FDRs were on board and kind of singing from the same songbook, as it were?
Yeah, I would say that was bumpy as well. And because we weren't effective in our messaging, and the first time we sent something out, we got such a low response, we realized we weren't communicating well, and that was our job to learn to speak their language. They weren't going to speak ours. These vendors have many other people that they support, and we all use different terminology. And so we realized we were ineffective, basically. And if we wanted to move the needle on this, we had to change how we talked about things. And so, Kate, I think you have an example, even things as simple as the data dictionary, if you want to talk about that.
Sure. So as Jenny has talked about and Allison talked about, we wanted to work very closely with the business to help them be accountable. And we knew it's a great example of how the BPAL role really came into play for us. That rather than compliance, working with delegates and individual delegates to say, this is what we're looking for, this is how we're defining it, to have the people who are closest to that information, the business partners of those delegates and those FDRs, to talk to them so that when we look at the data dictionary, for example, where we define how we pull the information, how we define that cell in that template in order to provide the appropriate information and to make sure we're all on the same page, to really tweak that. And our business partners work closely too with their colleagues and FDRs to make sure that if we needed to change the language a little bit to speak their language and help them understand and be more successful and to speak our language as well, we did a lot of work in that area.
Yeah, and I would say it's an ongoing challenge. It's even when we got the audit notice, we did have one delegate to say, prove it, send me your audit notice, or we're not going to start this process going. So right when you think you've made progress, we're thinking, really, of all of the stuff we've talked, you want to, you're our vendor. And so we have more work to do on it, but I think we learned we have to be flexible, but we still have to standardize things. And so that was the role we could play, is where can we add a little flexibility in, like Kate just talked about, but then where do we have to standardize our messaging? Because if it's not standard and it comes in too many different formats, we're never going to be able to compile this and have it look like it's coming from us, which is exactly what CMS's intent is. If we delegate this out, that's our issue, not the person who's delegating it. I don't know. Do you have anything to add, Allison?
No, I think that covered it.
Okay.
So you talked a little bit about sustainability and the changing role of some of your business partners from when you started to where you are now. Can you talk a little bit about how did you strike a balance with them so that the business partners are still able to achieve their mission while also assisting the overall organization with compliance?
So for the audit, and I'm guessing we have a lot of business partners or some out there, would say we probably didn't achieve a great balance. There was a great imbalance during the audit, and that was another risk we had to watch for, is to say who's watching the rest of the business as we're pulling this together. So that was a challenge and something we were watching carefully and making sure, because we had to pull so many people in, and I'm sure others who've been through the audit, when this comes, it does bring you to your knees, and not just for a week or two. I mean, it came March 20 whatever, and it brought us till the audit was done, so now we have a longer time period. And so there's just very critical things, fortunate for us, the pharmacy, it was after all of the pharmacy, 1-1 pharmacy work came, and it was before AEP. So for those organizations that go through it in those more critical times, I think that's an even bigger risk, because there's so many of those are just some cyclical things that you just can't avoid. So I would say there was an imbalance, but at the same time we talked about it as a business, and as a leadership team we talked about it too. When I went to our executive leadership teams, we would say everybody just has to focus on what their deliverable is for the organization right now. I've got the audit, and I'll come to you if I need anything. If not, you go and do your business things. Same with our business folks. We had a lot of people that wanted to come and help with the audit, and we had to say no, because we needed people back, doing the day-to-day work. So it was also saying thank you for that offer, but the biggest role you can play right now is to keep the day-to-day things going, so that all the things that are part of this time frame in this universe don't show up 3 months later that we missed something because we were focusing backwards. So it was a very focused effort to manage that, what I saw could be a potential risk.
Okay, one more question. So you had mentioned the numerous resources that CMS has put out there and how you've utilized them, so thank you for the plug. I appreciate it. But for the other sponsors out there who are listening to this, and you mentioned how it's been helpful to you to hear from others, if there's one thing that you think a sponsor could implement in their organization today, moving forward from all of the resources you've mentioned, what do you think would help them most to improve their performance in an audit?
You know, it's hard for me to, because some of you may have already figured all of this out, but for us, the more clear, simple, effective reporting has really changed our program. We always gave them too much information, and so we took on the responsibility of prioritizing what those are. We work very closely, so for example, our Chief Operating Officer, we don't tell him what the risks are out of that team. We work with them and say, from our data, this is what we're seeing are the biggest risks. Do you agree? And so we align on what those are and really make sure we're addressing the ones that have the most impact to members getting care or members getting medications. There's a lot of other issues that people are concerned about, but you simplify it pretty close. And then we look at the protocols. And then say, and if this comes in, this is what it's going to look like. So I would say we have more simple, I could say sophisticated. It's not a fancy reporting. I mean, you saw what Allison created up there. And sometimes we do reporting and it doesn't work, so we go back to the drawing board and say we didn't get the reaction we needed from that. We need to tell this in a different way. But like all of your executives, are so busy and have so many other things coming in their direction. Is how do we get something in front of them so they know what our ask is. So at the end of each thing we say, here is our ask, and here is how you can help us. And sometimes it's just continue to support us, but if this doesn't happen, I'm going to be coming to you with this. And other times it's a specific ask of what they need to do within their team. So we've gotten much more clear, and for those of you that have great reporting and effective, I would love to see any things you do or things you get in front of your executives as well.
Well, I'll stop, taking all the time for questions in the last 10 minutes, let you all ask some questions.
All right, if you have a question in the audience, if you would please step forward to the microphone, introduce yourself, and let us know where you're from, please.
Yeah, hi, Scott Levine, Affinity Health Plan. First of all, I absolutely agree that there is a tendency to focus on the universe's timeliness, accuracy, and completeness at the expense of CPE. I mean, it's like the shoemaker's children not having shoes. So you're absolutely right, but that's not my question. I'm interested in terms of your delegated vendors. Do you have them send in information on a monthly basis or an ongoing basis, or do you deal with their data on an ad hoc basis?
So I'm going to turn that to Allison because she's over our detection team.
Yeah, so it is on a monthly basis is what it generally is that we've gotten to. So for the Part C claim delegates that I talked about, it was as we could get it in the beginning when they would have the ability to send it to us. But now that we have this sustainable process in place, they are sending it to us on a monthly basis.
And do you find that you have problems in getting that information on a sustainable basis in terms of turnover at the various delegated vendors, or just them having other priorities, or is that not really been an issue?
No, that's definitely an issue. Getting everyone to respond. We try to do everything together as well, so we want all the vendors to respond at the same time. Now that we have this oversight team built within the business, it's really their day-to-day life, working with the vendors to understand, are you going to be able to provide it to us? If you're not, what are the reasons? What are we going to do to get it? But I'd say that's an ongoing problem of just the ability to get the information and assess it.
And I also agree that compliance can't be the operation. They can't be a replacement for the operation. They need to be compliance. These are the rules. This is what we're doing. This is where we need to go. Thank you.
Yeah, I just to add to that as well, I would say part of what we've focused on with the delegates as well. Many of them are experiencing audits from other organizations, And so I think that has helped as well, that it's not just us asking for this, that the more of us that are asking for it, it becomes, if they want to contract with our type of businesses, they have to build that into their processes. So that's a slow journey, but we are seeing that it's not just us asking for this, they're hearing it from other organizations. So there's a little power in numbers for us on that one.
Really great presentation. I'm Garrison Rios from LA Care. I'm interested in knowing how much support you provided to your delegated entities if they came back to you and said, we just can't provide this data, we don't have the systems in place. That's what we've experienced with some of our PPGs.
We provided support. I think there were a few areas where we really had to meet with the most senior leaders and understand what is preventing us from getting the information that we're requesting. There hasn't been a significant amount of the inability to, I think just based on the vendors that we do delegate with, but we do have instances where, we'll go to them and they'll say, can't happen, we don't even know how to pull that information, and we'll, work, like what Kate said, work with them to really understand, okay, these are your systems, this is what we're looking for, and spend that time with them if they need more dedicated time. And then have our business partners, if they need to go out to the delegate and understand exactly what needs to happen, have them spend that time so we are getting what we need.
Hi, I'm Adrienne McPherson with University of Maryland Health Plans. I was wondering if you had any issues getting senior leadership buy-in for your internal auditing for compliance, and if so, how you overcame that.
So Kate is our part of our audit team. I don't know, Kate, if you want to talk a little bit about what your team does?
Sure. So within our team, we have both regulatory audit and we have internal audit. And they work very well hand in hand. And I believe that a lot of it is what we've talked about before in terms of reporting and really saying that it's all about the member. I mean, we really want to do what we can and the best we can for our members. It's also about performance, how are we performing? Because the two really go hand in hand. So making that link with senior leaders to say, to Jenny's point, we don't want surprises. Well, the way we're going to make sure we don't have surprises is that if we do have these internal audit processes in place so that we can understand and gauge our performance and look for those risks and make those fixes, again, for our members, but also in terms of our performance. Because if we wait for a regulator or an external auditor to come in, it's too late. It's too late. So I think that's the big thing, making that tie, pushing about how important it is to the member, and you have some successes with that, and people really buy in and they understand the value of it.
So I'll add one other little tip that's been helpful. We meet with our region quite frequently, and we do share our internal audit plan with them, and we tell our business leaders we are. And so when we have them engaged in figuring out what that, so right now the 2016 internal audit plan, each of our executive leaders over, our salesperson, our operations person, they bought into that. So then we do share it with our Region 9 team and have them look at it to say, you see our CTMs and other things. Is there something on here that you think we should put on that we haven't? Knowing to our leaders, if we're not getting the pushback, they know we've shared that with our regulator, who's our customer and our regulator. That's helped a little bit, put a stick to that to say we made this commitment and we've shared it. So if we're not going to do an audit or we're not going to get that done, and this is an area we've had increased CTMs or something, what is your story going to be when the regulator asks about it? And I would bring that leader to talk about that. So engaging them in the plan, sharing it with, being transparent with our regulator, and then and there are times we don't do an audit because of certain things or priorities, but we just have to then be ready to explain why we didn't look at that and what other monitoring did we do in place. So it's a little risky, right? Because you're sharing it and you have to deliver on it. But I think what it's added is the discipline and focus around to make sure what we committed to in that audit plan is there. And if not, we've talked about as a leadership team, why not, and what other risks took place for that we can explain it to CMS.
Great, thank you.
Okay, thank you for your questions. We have time for just one more question, and I know that we have more than that waiting, and we do appreciate your questions. Please hang on to those because we will have time at the end of the day to address the ones that we have not had time for during this session. So please go ahead with your question.
Hi, I'm Lynn Wardinger with Geisinger Health Plan, and my question is fairly quick. You mentioned that submitting questions to the CMS mailbox was critical. Which CMS mailbox, and were there more than one? And are there other resources too? You talked about tools, and I think we're all aware of like the best practice memos and the job aids that have been sent out, but were there other things that you also used?
So I can't tell you off the top of my head which CMS mailbox, because we would gather those questions and then there was a person who'd submit them. I know we're going to answer questions this afternoon, and we can share that information with you then to give you to be more specific about that.
Nope, go ahead.
So we'll share that information with you. And in terms of tools, it's really some of the things that you just mentioned, looking at best practices memos, finding out what you can with industries, being as creative as you can be. It's amazing how many people that as large as this industry is, it's very small sometimes. And just the relationships people have and they've created going through conferences or working just in this industry, to literally pick up the phone and call someone and say, can you just give me some insight, or what do you think about this? Or building that network is very helpful, and we find that people are helpful, and we're happy to be helpful as well. So
yeah, and I think so when it comes to the specific audit protocols, we use the audit mailbox. I don't know exactly what it is off the top of my head, but it's whatever's listed in the protocols as to where to ask questions would be any of our protocol related ones. Whenever we get memos or anything else where we're asked to comment, we always use that specific mailbox. And we have a couple of people on my team that actually go out to the CMS website on, a weekly basis. It was more often when we were preparing for the audit and then undergoing the audit, just to look at what's new enforcement actions that have been posted, what did they get them for. We look at the star ratings, any of the results that we can find that can give us some information is what we use to really get us best prepared and have us be able to communicate with our leadership exactly what we're doing.
Okay, that's very helpful. I think we're already using those tools, but wanted to make sure you didn't have something else that you knew about that the rest of us might not. Thank you.
Yeah, thank you.
All right, thank you for your questions. And again, I understand that there are additional questions. Please hold those until the open Q&A session at the end of today, and we'll be happy to address those at that time. I would like now to thank our panel from United Healthcare and from CMS for sharing their experiences and findings with audits with us today. Thank you. You're welcome. All right, we are going to go ahead and we are going to evaluate this session. So if you would like to evaluate this session, please enter A. We are also going to be evaluating a second session after this one. Session number 1 we had a technical glitch with, so we are going to give you an opportunity to reevaluate that. So if you could hang on with us for just a moment. As you are completing that evaluation, I would just like to let you know, after we complete the second one, we are going to be going on a 60-minute lunch break, and we are going to begin promptly at 12:45 this afternoon. For our in-person guests, please feel free to visit the cafeteria downstairs or the farmers market, which is outside downstairs. And if you pre-ordered your lunch, you can pick it up at the Jazzman Cafe, which is right outside the cafeteria. And now we are going to move to session number 1, and we are going to reevaluate session number 1. So if you would like to give that a try again, go ahead and enter A. Thank you very much, and follow that link and respond to the questions. And once you are finished, please enjoy your lunch, and we will see you promptly at 12:45.